Hello, everybody. This is day two of me preparing for my psychiatric nurse practitioner certification exam. I do have a review class coming up on Monday. I'm looking forward to getting started on that final review. I have been studying on and off, taking tests, certification tests, preps, mock exams, questions like that. And depending on the day and the energy, I've scored anywhere from 75, 76%, as high as 89 to 92%. So I feel like I'm doing pretty well on content when it comes to reviewing the test questions, using test strategies and things of that nature. Today, I think I'm going to cover the scales. I've typed up an outline based on material that I've reviewed. So I'm going to go down 9 or 10 scales, a little bit about what they are, the score, what is, mild, moderate, severe, normal, things like that. So we're going to get started with uh, scales that measure mental capacity or cognitive capacity. So we're thinking like function and decline, as you would see in like dementia patients. So the first scale we're going to cover is the St. Louis University medical status, or the SLUMS test. It's a cognitive screening tool that's used to detect early signs of mild cognitive impairment and dementia. Um, it assesses several cognitive abilities such as memory, attention, language, executive function. And on this exam, or this test, survey, however you want to call it, there's 11 questions and tasks that help the client, or helps you judge the client based on things related to memory, attention, recall, language, orientation. I think there's some calculation, like counting backwards, numbers in reverse. But we're fixing to go over the examples of the tasks that are included in the SLUMS test scale. So orientation questions like what's today's date, what year is it, where are you at? So these are general orientation questions that you would ask in your like normal neurological exam when you're in nursing, when you're doing your nursing head to toe. So some of this stuff bleeds over. You're familiar with it from your practice, so you're integrating it into this scale on your psychiatric practice. So memory recall, so it's going to be naming 5 objects after a delay. So if I say spoon, shoe, clock, fork, dog, you ask a couple of questions, interact with the patient, then you ask them to recite that back: shoe, spoon, clock, fork, dog. Almost wasn't able to do it myself. Maybe I've got a little bit of dementia. Um, I'm 45, so my dad joke is I have half-heimers because I'm halfway through my life, but I think I'm the only one that finds that funny. Let's see, basic math calculations, even involving money, like $1 and $1 equals $2, $5 and $5 equals $10. Are some examples of that. The naming animals is many as you can, holding up cue cards, or if they're drawn out, or slideshow on a electronic device like a tablet or a phone. So mouse, shrew, sloth, anaconda, gar, megalodon. The things that we see in everyday life in the South. Just kidding. Probably possum, cat, skunk, squirrel. In the South here. Reciting numbers in reverse order. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Or you can do something like deducting a certain amount of numbers away from a number. So like 100 minus 5 is 95, minus 5 is 90. Have the patient count backwards. Can they tell time by reading the face of a clock? Something that's not digital. It's got to be analog based. That is something that would allow you the ability to understand what their reasoning and understanding is, their cognitive function and recognition. Shape comparisons, triangle, square, circle? Are they able to, can they pick those out? And then comprehension of a short story. So you tell them a story. Do they understand it? Can they name key points? I think I've got that. Understand that one right. And then this is used again. The slums test is used for those that you suspect cognitive impairment in, and you're trying to screen them to see if they have dementia or where they're at in their cognitive decline. So the scale is 0 to 30 for the slum. 0 to 20, if you're starting at the bottom, actually indicates dementia based on your scoring. 21 to 26 is mild, and 27 to 30 is normal. The mental status scales, the 0 to X number is actually the worst. All the other scales, the closer to 0 are, the better off you are. So something to keep in mind when you're studying for your exam, when you're doing your reviews. I promise that's my dog sleeping in the hallway. I've got 2 other dogs asleep behind me on the floor. His name is Titus. The MMSE is the mini mental state exam. It's used pretty widely. It's a cognitive screening tool similar to the slums. It's used to assess cognitive function and impaired to excuse me. It's there to detect cognitive impairment and assess cognitive function. This includes dementia. You, as the surveyor, will ask a series of questions, and you task series of questions and tasks that evaluate various abilities, excuse me, such as orientation, attention, memory, language, visual spatial skills, attention. I think that's it. The MMSE is a 30-question survey. Each question is worth 1 point with a maximum score of 30. So this range is 0 to 30. The slums is 0 to 30. So the range is the same for both. Now, things that you would ask, is the, date and time, location. Again, the orientation question. Can they recall 3 objects after a delay? Again, very similar to the slums exam. Counting backwards by 7s, or spelling a word backwards. I think world is the one that's most commonly used. Can they name objects like pencil, watch, glasses, headband, fishing pole? There we go. So in the NIH, which is used to score patients when you suspect a stroke, there is a section of the exam where you ask a patient to name certain objects: a feather, a hammock, a chair, a watch, clock, gloves, glasses. So it would be something very similar to that you're integrating into the MMSE. Can they read and follow written instructions? Can they write a sentence? Can they copy geometric figures? All things that would be included in the MMSE, again, to check cognitive function and see where their abilities lie. So the MMSE, it's not diagnostic, but it's rather a screening tool. A low score on the MMSE may indicate the need for further evaluation by other healthcare team to determine if this is cognitive impairment. So if you're seeing a patient and you see that they score low, and they don't have a dementia diagnosis, you may want to have a medical professional look at them. As a psych provider, some things within the medical spectrum, you're not allowed to dip your toes in, so you would refer this patient, for further evaluation. If you have someone that has a status change based on family, a mental status change based on family's, report or spouse report, whatnot, and they bring you to you because they think that, they have dementia, they may need a CAT scan to rule out, something else organic. They may need blood work to rule out electrolyte imbalances and sugar issues, renal failure, encephalopathies. And you could have some liver disease and or they could be alcoholic and they developed some kind of encephalopathic um, process that has caused their mental status to change or their cognitive status to change. So ruling out medical conditions is really important. Again, this is a screening tool, and if you suspect that there's dementia there based on a low score, then following that up with a medical exam to rule out um, any kind of organic issues that's not related to psych or just natural cognitive decline, then you're doing your due diligence and advocating for that patient by treating what's there. And then, if nothing shows up, then you can approach the diagnosis of dementia or whatnot. So you go from there. Those are the two mental status exam or the two mental screening tools or survey tools, scales that I'm focused on right now. The MOCA is another one. I may do something on it in my studies in the future, but these are the ones that I'm just kind of focusing on now. The next scale is, the depression scale. There are three that I'm covering. The first one is the Hamilton Depression Rating Scale, for short known as the HAM-D, or the Hamilton Rating Scale for Depression. It is administered by the provider. This assesses, the severity of depression in patients. Max Hamilton in the 60s established this or designed this to use in clinical settings. So the HAM-D has a range of 17 to 21 items. There's a couple of different versions, so it depends on which one, but they all score pretty much the same. And again, it's utilized to measure the depth of depression that the client is in. So as you go down the items, they're scored 0 to 4, 0 to 2, depending on the question. And it covers things like depressed mood, so sadness, hopelessness. Are you pessimistic and just negative all the time? Feelings of guilt or worthlessness, thoughts of suicide. Of course, on that note, if someone is having thoughts of suicide, you can stop, investigate further to advocate for their safety. Do you have a plan? Do you have resources in place? Is this something that's imminent? And then you can take steps to get that patient help. So if they have a plan and they have intent and they've opened up to you, then that's even grounds for hospital admission. So if you're in a clinic, you would call emergency services to get this patient, potentially get this patient, seen in the emergency room setting and not in the clinic setting. Insomnia, so staying asleep, falling asleep, waking up early, all signs of poor sleep patterns or insomnia. Work and activity, so do you like doing fun things? Do you find joy in the things that you used to enjoy? If not, then some points are there. Do you like your work, or have you lost interest in work? Have you ignored your hobbies? So, oh, I'm sorry. Psychomotor retardation, so slow thoughts, slow movements, psychomotor agitation, so restlessness, the inability to sit still. Are you anxious? This can be worrying, so psychological, so worry, ruminating on thoughts. How am I going to get this done? How am I going to get this paid? Am I a worthy spouse? Am I a great parent? Am I a good friend? These things are all anxiety, psychological based symptoms of anxiety. Now you can have somatic symptoms of anxiety. So those would be the physical symptoms. So shortness of breath, heavy chest, palpitations, sweats, tremulousness. So all those things are physical symptoms of anxiety. You can have somatic symptoms, like stomach issues, constant nausea, stomach cramps, poor appetite, fatigue, cloudy thoughts, or just brain fog, poor concentration, all these things are covered, when you're asking the questions down the scale. And I don't have a scale handy, to hold up in front of the camera, but just saying these things out loud helps me, and I'll go back and rewatch these as I will. So the scale is 0 to 76. 0 to 7 is normal, like I said. On the depression scales, the closer to 0, the better off you are. So 8 to 13 is mild. 14 to 18 is moderate, and anything over 19 is considered severe. Now, if you can remember the moderate range, then if you're, anything less or above is, you're okay, or, you're not okay, and you probably need to, provide some form of intervention. But if someone says, Tom Jones presents to the clinic with thoughts of depression, feeling worthless, hopeless because of a job loss. And you go down the Hamilton Depression Rating Scale, and he scores a 21, that's greater than 18. So that's pretty severe. There needs to be intervention. Or it could be on the lighter side of things. He's just unhappy with his role in life, doesn't like his job, thinking of a career change, but, he's a 7 or 8. Those things can be hopefully worked out through, therapy and, realigning life goals, and, maybe not require medications, that can be utilized to treat depression. So, like maybe you would for the moderate and severe, which you would want some kind of intervention there to prevent complications down the road. Let's see, the next scale for depression is the PQ or PHQ-9, or the Patient Health Questionnaire 9. It's a self-administered tool, where the Hamilton D scale was administered by the clinician, but it also screens you for depression and measures how bad your depression is. And it's PHQ-9 because it has 9 questions on there. The questions are, do you have little interest or pleasure in doing things? And, each question is 0 to 3, where, 0 is, okay, or, little interest in pleasure in doing things. 3, I don't find any pleasure in doing anything. Do you feel down, depressed, or hopeless? You would score that 0 to 3, as you would all of these. Trouble falling asleep, staying asleep, or sleeping too much. Do you feel tired, or you have no energy? Do you have a poor appetite, or are you overeating? One of the signs of depression is a change in appetite, either eating too much or eating too less. Feeling bad about yourself, like you're a failure. You've let you or your family down, your coworkers down, whatever the case may be. Trouble concentrating on things. Let's see, like you can't read a paper, you have a hard time remembering content, you get bored easily, trying to watch TV, but you space off, you can't remember what you wrote or what you were watching. With all the stress that, was in school and all the changes that were happening in my life, that was one of my big downfalls, because, I was depressed and anxious and nervous, and, all of that related, to school and life change and, other dynamics. But had the hardest time some days remembering what I wrote or remembering what I read, completely spacing off. Feel like I had to read the same page 15 times just to try to get through the content. So again, that could be a symptom of depression. Let's see, moving or speaking slowly. So did your speech cadence change to, well, I don't know, I can't seem to get it together, where that change in cadence, so that it's called decreased prosody. Your speech pattern is at a slower pace. That can be organic, that can be medication related, or it can just be depression. Let's see, are you fidgety or restless? So moving slow, speaking slow. You can be just the opposite, speaking fast, hyperverbal, super fidgety, restless, can't sit still. Or then you get to like one of the big thing is, have you had thoughts that you were better off dead, or thoughts of hurting yourself in some way, cutting, pinching, burning, things of that nature. So But all of those are scored, 0 to 3, and then you would take appropriate intervention depending upon the score. Now, for this one, 0 to 4 is normal, 5 to 9 is mild, 10 to 14 is moderate, 5 to 19 is moderate severe, and then 20 to 27 is severe. So this one has a moderate to severe scale. None of the others have a moderate to severe unless you get down into I think it's the substance use scalings. So that one's kind of confusing. So you're good, you're kind of good, you're okay, you're not so okay, you're very not okay. It's almost like when you look at these scales as they're rated, like you're trying to pick out a hot sauce, for your chicken wings. Do you want, naked, or do you want, the devil's urine? For the depression scales and whatnot. So that's kind of a little joke, but knowing where the client rates can help you, navigate intervention as they move, forward through their treatment. So that one, the PHQ-9 for depression, the HAM-D for depression, and then the third one is the Beck Depression Inventory. It is also a self-reported questionnaire that's designed to, again, check for severity of depression in individuals. Aaron Beck designed this in the 1960s, and there's been a couple of versions and revisions of this over the years, decades, and it's a 21 question test or 21 question scale. I don't have what it asked, but it right in front of me. But each one is also scored 0 to 3, like the PHQ-9. The scaling for this is 0 to 3 is minimal depression, 14 to 19 is mild depression, 20 to 28 is moderate depression, and 29 to 63 is severe depression. So we've done the 2 mental status evaluations, which is the mini mental state exam, and the St. Louis University mental status, or the SLUMS and MMSE. The depression ones that we've covered is the Hamilton Depression Rating Scale, or the HAM-D, the Patient Health Questionnaire 9, or PHQ-9, and then the Beck Depression Inventory. Again, the Beck and the PHQ-9 are self-administered, and the HAM-D is a clinician-administered exam. Now we're going to talk about anxiety, everybody's best friend. So, anxiety is a natural part of life. We should normalize our anxieties because sometimes it can be protective, like walking down a dark alley and thinking, oh my gosh, I really shouldn't be here, then turn around and leave the alley. A weird parking lot, a strange car. Your body has a way, spidey sense to tell you that you should not move forward, with the direction that you're going. So anxiety is a normal aspect of life, but it also can be overwhelming, and it can drive you into a tizzy. It can be mind controlling, emotion controlling, and it can ramp up, and sometimes it's really, really hard to come down. Anxiety attacks are no joke. I was with a therapist in my rotation, and she called anxiety the devil. Shara is an angel, but she's 100% right. Anxiety is something that we have to learn to contend with the best way that we can, and being able to give ourselves a grade or help our clinician, grade us on our anxiety can help us navigate intervention moving forward in our lives, whether it's medication or therapy and or both. So with the first anxiety scale, it's the Hamilton Anxiety Rating Scale, or the HAM-A. Max Hamilton invented this one. He did the depression scale. So the same guy, just focus on anxiety for this one. It is a 14 item exam that is each item is rated 0 to 4 as a not present for 0, and severe is the 4, and the total score, can measure the person's anxiety level. So, anxious mood, worry, anticipation of the worst, irritability. The second one is tension. Do you have feelings of tension? Restlessness. Can you not relax? Fear. Are you afraid of the dark? Strangers, spiders, snakes, chocolate, the direction east, Chinese food. You can be afraid of anything. Insomnia. So poor sleep habits, not sleeping well, or not being able to go to sleep, stay asleep. There's an intellectual item on the exam. So this covers concentration and memory. Be able to focus. Can you remember what you're doing? Can you remember what you've read? Can you remember the next step in your plan for the day or for the week? Depressed mood. So lack of interest, lack of pleasure in hobbies, that withdrawal. So the depressed mood aspect covers on there. So there are 2 somatic flags on this exam or on this scale. One is for sensory, and one is for musculoskeletal. So the muscular somatic scale will be like aches and pains and stiffness and twitchiness. The sensory would be blurred vision, hot and cold flashes, ringing in your ears, tingling of your skin. Those are cardiovascular symptoms that you can experience with anxiety. If any of us has ever had a panic attack, you know that your heart beats fast, you start having chest pain, you have this heaviness kind of develop, and it's unsettling feeling. And tachycardia and palpitations can be synonymous, but not necessarily. Tachycardia is a heart rate greater than 100. Palpitations feels like your heart's beating fast, but it may not be beating fast. Oftentimes it is, though. Respiratory symptoms, choking sensation, tightness around your neck, short of breath. So imagine, I know a really good description of the respiratory symptoms. I was in a Brazilian Jiu-Jitsu class once, years past, and my instructor was my first lesson. He said, one of the most important tools that you can learn in jiu-jitsu is how to move your hips. And they'll teach you a shrimping technique that allows you to shift your hips from side to side and, kind of rise from the mat. And whoever's got your mount can be removed if you have a good technique. So this guy sits down on my chest, like sumo warrior style, and says, "Get me off of you." And I was afraid to take a breath. I was afraid to let out my breath because I thought my chest was going to cave. And I've never had a sensation like that before. I learned how to move my hips. The other sensation is it feels like Darth Vader is force choking you. So there's a scene in Star Wars where Vader force chokes, I think General Tarkin or Tarkin, and he's 6 feet, 8 feet away from him, and he's just holding his throat, and ultimately, Vader chokes him out. So it feels like that. It's awful. I've experienced that a couple of times in my life, both with anxiousness and allergic reactions. So 10 out of 10, don't recommend. Gastrointestinal symptoms, abdominal pain, nausea, cramps, poor appetite, just this vague, I think of kids that don't want to go to school. Mommy, I have a tummy ache, kind of thing. I just feel unsettled. Genitourinary symptoms. So when we're anxious, we want to pee. We have drank 50 gallons of water when we probably only had 2 cups all day. But when we're anxious, we're nervous. Bam, we got to go to the bathroom. Your autonomic system gets triggered, so you can have dry mouth. You can get dizzy. You can sweat. There's these, kind of fight or flight senses that kick in, and the dry mouth from breathing fast, sweating from being nervous, and just dizzy from breathing fast, and heart beating fast, and there's just a disorientation there. And then just during the interview itself, what's the client's behavior? Are they pacing the room? Can they not sit still in the chair? Are they fidgeting with a pen? Are they picking their nails? Are they flicking the seams on their breeches? So all these things you can score 0 to 3 or 0 to 4 and see where they rank. And for this scale, it goes 0 to 56. 0 to 13 is normal. 14 to 17 is mild. It's a very, very narrow window for mild. And then 18 to 24 is moderate. Again, that's what you want to try to remember. 18 to 24 is moderate. Then everything else that falls on the outside, is okay. And then greater than 25 is severe. So I don't feel like in the exam that they would give you a normal ratings. Feel like they would throw you somewhere in the middle just to kind of gauge a more complex thought process. For some of the questions that I've not had a normal. It's been more in that moderate range or even severe range. So what would you do in that instance? Advocate for therapy, medication, things of that nature. So the next anxiety scale is the GAD scale, or generalized anxiety scale, or for generalized anxiety disorder. Now, this is people that are really are uncomfortable with everyday situations. They have uncontrolled worry, excessive worry about everyday things. Going to the grocery store, oh my God, I can't go out and buy my milk. Going to school, there's too many people. The teachers don't like me. I have all this homework. Going to work, I can't stand to take care of another person. I can't stand to fill one more box. I can't stand to rotate one more tire. If I put one more nail on the board, I'm going to put one more nail in my head. I mean, you just are so nervous about things going on in your day to day that it almost paralyzes you and you can't focus. You tend to catastrophize things. This is the worst of the worst of the worst. A rock falls off a cliff. You all of a sudden think it's an avalanche. So people that have generalized anxiety disorder, they walk around constantly anticipating the worst. My health is bad. I don't have enough money. I'm going to be homeless. My family's going to leave me. My kids are going to get hurt. At work, my coworkers don't like me. I'm not going to be effective or efficient. And just all this stuff just clouds your mind, and you just get you all worked up, and you're not able to move forward, in your day, your life, your function, because of the significant distress that, anxiety causes. For the things that come along with anxiety, as the questionnaire kind of touches on, persistent worry about, a variety of things in your life that's really out of proportion with what's actually going on. If the solution to 5 times 5 is 25, you're thinking, well, 5 times 5 is 25, but 20 plus 5 is 25, and 10 plus 10 plus 5 is 25, and 5 plus 5 plus 5 plus 5 plus 5 is 25. And you just break these things on down, and it just, kills your mind, and you can't focus. Every situation and every event is the end of the world, and you just don't know why, and you can't even handle it. You want everything to be certain and definitive, and you just can't handle the uncertainty in your life. Indecisiveness. Oh my gosh. Do I choose the blue Band-Aid or the red Band-Aid, the red pill or the blue pill, McDonald's or Burger King, knee-high socks or ankle socks? It can be that simple. Do I use, Crest or Colgate, mayo or mustard? Oh my God, I don't know. Sweet pickles or bread and butter? It really is, those silly things that folks can get distracted with, and you're just not able to relax. You can't take a breath. You can't sink into your chair because what if something happens? What if something happens? It's raining outside. It's going to rip my roof off. It's not raining that hard, and there's no wind, but that's where your mind goes. Could be a tornado. Sky's not yellow, but oh my gosh. My house is not going to be protected. I'm going to get trapped in my closet. The washer's going to fall on me. Um, Seriously, people's mind just go all manner of directions, and the anxiety takes them over. It really does. You can't concentrate, and then your mind just blanks out. You have had white out poured in your brain, and you just can't see or think or do or say, and because the anxiety's got you all messed up. Physical symptoms of anxiety, fatigue, trouble sleeping, tension and muscle aches, as I mentioned, trembling and twitchiness. You're just nervous and easily startled, hypervigilant. Oh my gosh. Everything is a jump scare, sweat, nausea, diarrhea, IBS, irritability. These things can uh, come together and be controlled with adequate support, medications, therapy, SSRIs, CBT, benzos in emergent situations. But it's important to measure it, see where you're at, if that's what you're treating as a practitioner, knowing where your client stands. And for the depression and the anxiety scales, doing these session to session or visit to visit really is a hard, concrete proof that your client is getting better or getting worse. Mileage may vary, events of the day and things like that. And, you may start trending in the best and then have a really off day and, your numbers change. That's an outlier, based on the spectrum of things. But, you can do this every visit, or challenge your client to do this every visit, just so they can say, hey, I am doing good. On paper, I'm fantastic. I was a 4, on my I'm not doing so well, and now I'm a 10 because, oh my gosh, I'm the best. Today's a really good day. So you can use these as a means to show your client, hey, you are doing the work, you're doing great, and it can be reassuring for them. The last two things I'm going to cover are substance abuse scales, the clinical opiate scale, clinical opiate withdrawal scale, or the COWS, and then the Clinical Institute Withdrawal Assessment for Alcohol, or the CWA. Now, in substance abuse settings, inpatient and outpatient, these are great tools to gauge to see if your patient is coming off of an illicit substance that can actually be life-threatening. People struggle with addiction. We all know someone. If you don't, they're hiding it well, or hopefully you don't. But we see it on TV. We see it dramatized in movies, folks that have stuff. But if you look deep enough into the world and the world around you, we'll see someone that might fit this paradigm. But we'll start with the COWS. This is used to assess the severity of opiate withdrawal. There's 11 items that ranges from physical, psychological symptoms. So you can gauge where they're at in that withdrawal. And all of these are rated 0 to 4, 0 to 5. With anything greater than 7, you really should initiate treatment before the patient starts to snowball down their withdrawal symptoms, which can be very uncomfortable and very dangerous. So items that you assess when you are doing a CAL scale on someone, their resting pulse rate. So vital signs are going to be very important. And you're not just going to check their heart rate. You're going to check their blood pressure, because if they're going through withdrawal, that can be hypertensive as well. Are they sweating? Are they restless? Can they sit still? Are they fidgeting? When they're talking, is their lip quivering? You can see kind of a panic in their eyes or a restlessness in their eyes, but they're restless. Their pupil size, excuse me, they have bone and joint aches. Excuse me. Sorry about that. Where's that? Oh, restlessness. They're just fidgety. They can't sit still. They're anxious. Their pupil size, and they can be dilated. If they're going through withdrawal, they have achy bones, achy joints, runny nose, tearing up, so they can have the sniffles and not necessarily have allergies. So don't discredit, oh, I've got allergies. I take Allegra every day or Loratadine. But if you're dealing with someone that is an alcoholic, excuse me, someone that is abusing opiates, the runny nose can actually mean something on this severity scale. Um, they can be nauseous. They can have vomiting and diarrhea in the throes of withdrawal. They can have a resting tremor. Yawning is really big. So you might see yawning, runny nose, and tearing up. And then you need to suspect something. They can be anxious. They can be irritable and just short in their words. And that may not be them at baseline. It just may be the fact that they're going through withdrawal and it's got them kind of keyed up a little bit. And then goose flesh skin. So the hairs on the back of your neck or your arms ever stood up, the little bumps at the base of the hair follicle is called pular erection. When they kind of rise, that's noted in opiate withdrawal. So you score all of these. If 0 to 4, none, great. They're either not in withdrawal or they've cleared the withdrawal window. 5 to 15 is mild. So you can give them a PRN med, something like clonidine maybe. And then 13 to 24 is moderate. Now, anything over 13, you really want to have them on some kind of medication. So with like standing order medication until they get through their window. 25 to 35 is moderate severe, and then greater than 36 is severe. So these patients, are seen in the outpatient setting. They go to like mat therapy and then get Suboxone to try to replace the opioid, their opioid addiction. That's probably the big one, is the Suboxone or Subutex. So to try to help get them off of opioids. The next is the CWA scale, which is for, I'm sorry guys, which is for alcohol withdrawal. Also used in the inpatient setting, outpatient setting, to gauge, where someone is in their alcohol withdrawal window. So there's 10 items on this one. Some of these kind of are parallel to the opioid, minus a few differentiations. Nausea and vomiting, is it present or not? Each of these are scaled kind of widely, 0 to 7. On a 0 to 7 scale, how nauseous are you? Is there none to dry heaves to slightly nauseous? However the patient, scales it, it's kind of like the pain scale. Is what they say it is. Are they actively vomiting, which would be closer to the 7 side of the scale? Tremor, do they have a tremor, a visible shake or a resting shake? Are they sweaty? Especially like sweating at night. Any anxiety, they would rate that. Agitation, irritability, they would rate that. These next 3 is the big differentiators between the alcohol withdrawal scale and the opioid withdrawal scale. The tactile disturbances, so pins and needles, burning, tingling, pinpricks on the skin, auditory hallucinations. So are they hearing things that aren't there, that they don't hear normally when they're not in withdrawal? Which can actually touch on, folks that have schizophrenia. where one of the positive symptoms of schizophrenia is hallucinations. So don't automatically assume that you're alcoholic is schizophrenic or having some really bad like mood disorder, like depression with psychosis or something like that, when these only occur during their withdrawal window or their substance use. So this would be like a substance-induced psychosis kind of thing, but you're on the withdrawal side. You're going through the withdrawal, so these things can be present. And when they clear the withdrawal window, these things go away. They get better. If they don't, then maybe they have a secondary diagnosis there that you're unaware of. Visual hallucinations, so seeing things that aren't there, light sensitivities, headache, fullness, pressure in their head, and then just their orientation and a clouding of the sensorium. So are they disoriented? Are they confused? Do they know where they're at? Do they seem off? And all these things would be scored. Some of these are subjective by the patient. Some of these are observed by you. So you score it appropriately. On the rating scale, 0 to 9 is normal for CAL or for CWA. 10 to 15 is mild for CWA. 16 to 20 is moderate. And then anything over 21 is severe. And the recommendation is that if they score an 8 or higher, then you start them on some kind of medicine and you start treatment. I've seen Valium in practice. I've seen phenobarbital in practice. Phenobarb tapers are fantastic. They're my most favorite when treating someone that is going through alcohol withdrawal because it's neuroprotective. It prevents seizures, or at least greatly minimizes the chance of seizures. And once you get them through the phenobarb trial, because there's a cap, I think like 2,400 milligrams in a 24-hour period is the cap. I believe. Don't quote me on that. I'm trying to pull from memory, so if I'm off, I'll apologize. Correct me in the comments. But you try to get them phenobarb drunk or phenobarb intoxicated, which is ironic considering they came in intoxicated. But anyway, stumbling around, slurred speech, they're groggy, hard to keep awake. You kind of reach that check boxes of, all right, they've had enough phenobarbital. I have seen people get like the full 16 doses or whatever. I think it's 16 doses. And I've seen folks get, 6 or 7. I think the average is around 10 to 12 doses before they reach that phenobarb intoxication, as it is implied. And then they go to bed and they sleep for like 12, 16 hours, and they wake up and they're sober and they're good. And most times they're pretty solid. And then you stop the phenobarb. You don't have to do anything else medication-wise to get them through the withdrawal. Phenobarb, I think, has a pretty long half-life anyway, so even to get them through that 72-hour window, mileage may vary, then they're pretty covered. So but phenobarb works great. Just not a lot of people are comfortable with it because it puts patients at fall risks if they try to get up and stumble around. You might even need to make a patient 1-to-1 for a shift or two, just to make sure that once they wake up, they're solid, their footing is solid. And of course, that is staff dependent. Where I worked before, we didn't necessarily have the staff to make everyone on phenobarb a 1-to-1. Actually, very seldom did we ever. So it was up to the nurse and the team to really advocate for that patient. So, but with the phenobarb, you're giving it every hour, so you're in there every hour, assessing them every hour until they conk on out to La La Land, until they wake up, and hopefully they wake up feeling a better person, a brand new man, brand new woman. So, but I think that's it for the scales. This video has ran about 50 minutes. My other one yesterday, I think, ran 45. I know I do a lot of asides and a lot of talking. I apologize for the yawning. I'm not sure what we'll do next, but we will see potentially tomorrow. So again, the scales that I covered was the slum scale and MMSE scale for mental evaluation or cognitive evaluation, the depression scales and the Hamilton Depression Scale, the PHQ-9 and the Beck, and then the anxiety scales were the GAD scale, the HAM-A, and then the substance abuse scales and the CAS and CWA. So thank you for allowing me the time to remind myself and hopefully provide some insight to those that are watching. If I can improve, let me know in the comments. If no one ever sees this ever, that's fine too. I just thought that I would maybe try a different avenue of learning. So I see a lot of little mini videos, reels, and otherwise, and I thought maybe this would be something that can help me learn as well by saying it out loud. So again, thank you for the time, and I will see you on the next video. Have a good day.